Is it on? Yeah. Good morning, everybody. This is not very Latin American-like, but we're going to start on time. So I want to welcome everybody to our SWOG Latin America Initiative Symposium. We're just super happy that you all are here. We have guests that are going to be joining us virtually, so we also welcome them. We have planned an extraordinary agenda for all of you today, but before starting, there are a few quick things that I just really want to share with you. Many of you know that earlier this year in January, we have the privilege to get together with key leaders within SWOG to talk about the mission and the vision and where we're going with the Latin America initiative. And Dr. Blanqui has been kind enough to invite me to be part of the plenary session tomorrow to really talk more about this. I really want to invite you all. We, of course, have a lot of things to thank, and I'm going to say the thank yous at the beginning and not at the end, because I know that people have, meetings to go to. So, of course, the Latin American team, it's key, and they have made, this journey for me, of course, incredible, and particularly Dacia sitting right next to me. Ops office, the team has been just absolutely extraordinary, trying to help us, deal with all the challenges. So leadership, of course, Dr. Blanqui, and very, very importantly, the Hope Foundation. You'll know that the Hope Foundation supports us, supports the travel of some of you that are here. So Joe, thank you so much. And this is also a big happy birthday to the Hope Foundation, that this year it's going to be turning 30 years. So congratulations. So any of you, there's going to be a lot of activities around that, so make sure to be part of it. Make sure to, $30 or whatever we all can donate to contribute to this mission. But thank you so much to the Hope Foundation for helping us to exist. Now, back to what it's our agenda today. We are going to be together for the next 2 hours, and we have divided our agenda in 3 parts. In the first part, we're going to be talking about cancer in adolescents and young adults. And for that, we're going to have 2 speakers. One of them, Dr. Irene Tami, and Dr. Lucia Napi, who's one of the co-chairs of the committee. And then for the second part, we're going to talk about the Latin America activities per country. And as you probably remember, what we have tried to do in previous symposiums is to highlight one country each year, or each meeting. And this is going to be the time for Colombia. And then we're going to have like a super quick update per side. And then the third part, it's going to be a roundtable discussion with Latin American investigators. And we're going to have the participation of Dr. Lynn Henry and Dr. Michael Fish. They have been great supporters of our efforts. And we really want to keep everything on time, so we have ample opportunity to engage in these discussions, because we're really hoping that eventually, there's going to be, great ideas and next steps from that. So without further ado, I'm going to invite Dr. Irene Tami Maury to the podium. She's assistant professor at the Department of Epidemiology, Human Genetics, and Environmental Sciences at the School of Public Health at the University of Texas Health and Science Center in Houston. She's a member of the DEMC committee, among many others activities, and a great supporter of SLI. So Irene, thank you so much for joining us.
Well, it's my pleasure. Thank you so much for this kind of invitation. And most of you know me from through my work with tobacco prevention and control, but I am delighted to speak about one of the projects that I had the fortune to be part of the team in my 2 last years at MD Anderson, where I was for 10 years part of the faculty body. And it is a project that we did to better understand what was the state of the challenges that adolescents and young adults face when trying to be enrolled in a clinical trial. So as you know, there are a substantial amount of adolescent and young adults, and those are the individuals between the 15 and 39 years old with cancer each year in the United States. And is cancer, the mortality, the cause of mortality in this particular age group. And of course, we need to understand that the type of cancers that the AYA's population face differ from the pediatric population and the adult population. So it's a specific group that unfortunately is kind of disenfranchised by the oncology system. Is really lagging behind, as the slide states, behind pediatric and adult population in terms of clinical trials enrollment, and is estimated between 3% and 14% of all AYAs. Of course, there are potential barriers that we were thinking at that time when we proposed a study, could be perhaps challenges in terms of treatment at each institution, lack of available trials, or maybe insurance status. So one of the first things that we did as a group, and this, again, as I mentioned, this was a great group that we had at MD Anderson, led by Dr. Michael Roth. He is an associate professor at MD Anderson, part of the pediatric department. And I was invited to join the team because of my qualitative background, interviews, focus group, qualitative analysis. And the first thing that we did is, okay, let's learn what is in the literature about the enrollment of adolescent and young adults in cancer clinical trials. And this is the inclusion criteria that we use. We only review English written articles and papers. Any type of analysis was included, either quantitative or qualitative analysis, but it was important for us that these papers included any type of measure or perceptions of barriers and facilitators for enrollment in of this particular population in cancer clinical trials. Again, it was AYAs, the population of focus. And we also set up that 75% of the sample on each study needed to be between 15 to 39 years old, with a median of 15 to 39 year range. And the exclusion criteria is that, well, if it was just a commentary paper or a literature review paper, then those papers were excluded. And this is what we found. I can speak to you specifically about how we excluded, like duplicated papers found in the search, or perhaps didn't meet the age criteria, or it was not peer-reviewed, the paper. But from 1976 to 2019, only 13 papers were published. That's astonishing, considering that this is an important group that deserves also have access to cancer clinical trials. And this is what we found. And I'm not going to dig, the slides can be shared to you, but sometimes the papers reported is that the clinical trial is not available in those specific centers or institutions, that it is not IRB approved, or the challenge to approve this type of trials, because it's more complex when you are dealing with minors. It requires more regulatory processes. And then age restriction, the cancer stage, sometimes the physician involvement. The physician is so busy that it doesn't have the time to kind of give the green light to a trial and present that opportunity to the family or the young adult. And then you see in the last box, I'm a clinician by training. I'm a dentist, and if I would review this paper, I wouldn't have that is the clinical trial accepted by the patient, because I think that all the patients will accept is the problem is on us, how we deliver that, how we provide the entire information, how we convince the patient that this is an opportunity. But nevertheless, you can see that there is lack of interest in clinical trials. Again, I would like to flip this, and did we convey all the information to this family, to the individuals? Health literacy. Are you conveying that information in a language that can be absorbed and understood by the family group? And concerns about the treatment efficacy, parental preference versus the opinion of the adolescent, and many other challenges that are associated to this enrollment. And then the facilitators, and you can see that there is plenty that we can do at the institutional level, at the professional level, at the patient navigator level, to change that those numbers of enrollment of adolescent and young adults in cancer clinical trials. So the systematic review is there, and if you shoot me an email, I can share that paper with you. But with these few existing studies, the next step for us was, okay, let's run a mixed method approach study to better understand what is going on in the United States at this time. And we wanted to kind of understand the system level, the institution level, and then the individual level factors associated with this poor enrollment. And we have a second paper based on that qualitative effort that we run in the NCORP site. And for those of you who are not familiar with what is NCORP, is a network of community settings across the United States. And some of them are also targeting minority and underserved populations. In the United States, minority populations are Hispanic population, African-American populations, LGBTQ+ population. So, and this is important, particularly with the efforts that SWOG is trying to print across all the committees in terms of diversity, inclusion, equity, and access to cancer care. So understand also that each of these site locations has kind of their own network, a satellite number of clinics that belong to that site. So it's more than that of what you can see in the map. This was our approach. We have a criteria selection where the NCORP site should have more than 50 total enrollment of individuals more than 15 years old, 15 or more years old, then at least one AYA enrollment in the past 2 years, and also one AYA enrollment of individuals with patients of 40 years or older. Why this? Because we know that that group enrolls more in clinical trials. So we wanted to learn what they are doing that we are not applying to the AYA population. And then we also understand that each of these NCORP sites can vary in terms of AYA enrollment. Some are very successful enrolling this population, others are doing poorly. So we wanted the whole perspective of this problem. So we make sure that in our selection, we have at least one affiliate, and those affiliate are the satellite clinics that I mentioned to you of each of the NCORP sites that has at least 10% of AYA enrollment in the entire proportion of cancer trials enrollment. And then also we have those that we call low enrolling affiliate sites with less than 3%. So overall, we have 18 NCORP sites that were eligible, and we approached 15. And in each of these 15 sites, we took and consented the first 5 stakeholders who contact us. So the process was that we sent the information to the PIs and to the administrators, and they were distributing the opportunity to participate in the study within their institutions, and then they will contact us. And by these stakeholders, we are talking about research nurses, the PI, the patient navigator, all these individuals who play a key role in AYA enrollment in cancer clinical trials. This is pretty much the summary of what I mentioned to you. And once then the individual contact us, sign the informed consent, we set up the interview that happened online. This is pretty much the distribution of the type of stakeholders that were part of our study. 5 were principal investigator, 4 administrators, 11 research nurses, and so on. And it's the list of barriers that we found that they reported to us. Insufficient staff and resources, no available trials. The location of the trial site sometimes is a barrier for those patients that may be willing to enroll, but who are not perhaps having the financial resources for transportation, parking, and everything else, particularly with those underserved and minority population, which is where we are striving in SWOG to be more inclusive. And regulatory burdens, as I mentioned, and contacting the AYAs, and then the facilitators. And I'm not going to go through each one of them, but these are things that we can take advantage if we systematize and create procedures, and we initiate a really strong conversation between all the stakeholders involved in the enrollment of AYAs in cancer clinical trials. Here I'm summarizing this potential solution and educating the stakeholders, incentivizing the enrollment of AYAs, creating tailored screening processes, providing feedback to sites on AYA enrollment, and formally designing local AYA champions. So this is the take-home message. There's an urgency to develop and evaluate interventions aimed at increasing AYA enrollment in the United States. But what is going on in Latin America? Do we know? I did a search and I couldn't find that many papers, actually just few reviews about what is the status of AYA enrollments. So this is something that perhaps as a group, we can convene maybe to initiate a literature review in this search and cielo in our databases. And with that, I will conclude. Thank you so much for your attention. And I'm open to any question you may have.
Irene, thank you. That was wonderful. And I think that really, like opens this big field for discussion all through the next 2 hours to what is happening in Latin America, since we know that in many of our countries, we do see a young patient population, probably sometimes even much younger than what the statistics in the United States show. We are very tight on time, so we may have time for one question if there's somebody that has any. Okay, if there's none, then we will keep moving on with our agenda that I think it's totally going to complement what you were just talking to us about. We have the pleasure of having with us today Dr. Lucia Nappi. She's a senior research scientist at the Vancouver Prostate Center in Vancouver in British Columbia. She's the chair of the Adolescent and Young Adult Committee in SWOG. Thank you so much for accepting our invitation. And Dr. Nappi is going to talk to us about what's happening at the Adolescent and Young Adult Committee, since we all hear, about this importance and really highlights the relevance of and challenges of studying this patient population and bringing clinical trials to them. Thank you, Lucia.
Thank you very much for the invitation. So I'm going to talk about clinical trials and research in the adolescents and young adults with cancer population. And I agree, this is perfect continuation of what Irene said before me. So I don't have disclosure that are relevant for this presentation. So first of all, let's define what AYA cancer is. What kind of cancer do we expect? What kind of population is represented under this definition? So the definition has changed like often during the years, but right now what we call AYA cancer patients are patients with cancer who are diagnosed with cancer and they're aged 15 to 39. So this is like the most current, I would say, definition of AYA cancer. And it's not very common, represent only 4 to 5% of all the cancer that are diagnosed each year. There are special issues or special characteristics that define this population. The first is that the 5 years relative survival for patients with cancer diagnosed in the AYA range is much lower than the same survival for children for most of the solid cancer or hematologic cancer that we have analyzed. So, and that's still the case. Most of the AYA cancer did not show any improvement in overall survival since 1992, which is like something that we have to deal with. And the annual percentage change in the cancer that did show a change in overall survival is much lower when we compare this overall survival to the same cancer diagnosed at younger or older age compared to the AYA population, so 15 to 39. So why is that? I think that we have multiple reasons for that. These are the data that show what I just said. So this is the annual percentage change in overall survival in patients with cancer diagnosed at the age 15 to 39 in the red box, compared to patients with the same cancer diagnosed at age younger than 15 or age older than 40. So as you can see here in the bottom, we have the good news. So those are the cancer which APC was more like higher than 1 from 1992 to 2006. And there are certain cancers that are very important, and I think we have to mention like Kaposi sarcoma, the non-Hodgkin lymphoma. There is like a very conspicuous group of cancer patients who had a very, very small improvement from 1992 to 2006, so less than 1. And then the cancer actually had a decrease in survival. And I think this is very ugly if we think about the improvement in overall survival and treatment care and treatment options that we have seen since 1992. And within these, we have a lot of sarcomas, unfortunately, bladder cancer in young age, which we know is notoriously have as a notoriously poor prognosis, and eye and orbit cancer. So there is definitely a lot of room for improvement. Any change since 2006? So this is an epidemiology study that analyzed patients in the AYA population since 2016. And as you can see here, the cancer are like divided by age. So within the AYA spectrum, we have cancer diagnosed at age 15 to 19, 20 to 29, and 30 to 39. So in all these 3 groups, there has been an increasing of the incidence in both males and female with cancer, but the mortality is decreasing. And again, when you compare the younger patients within the spectrum of AYA, this mortality decrease is much more significant than the same mortality trend observed in patients who are a little bit older, so from age 20 to 39. And especially in female patients age 30 to 39, the decrease of mortality is almost plateaued. And this is most likely related to the flattening of survival curve observed in breast cancer patients. This is the same data, but dissected on the cancer subtype. So we can see that in male, as expected, testicular germ cell tumors is the most frequent and has had an increasing progressive increase of the incidence over the years. It still is the highest incidence solid cancer in young men. And there are certain cancer that deserve a specific mention. For example, thyroid cancer in female age 15 to 30. It has been a huge increase in incidence in these patients population, while breast cancer is more or less flatter in terms of incidence. So what are the factors that uniquely affect AYA patients with cancer? So the first and most important thing is that this is a no man's land. So these patients are between adult patients with cancer and very young patients with cancer. Obviously, there are specific issues for this patient population. They are in their development stage, physical and psychological. The presentation of the cancer is very different to what we usually see in younger, older patients. Their access to care can be very challenging in a very young age where they are still figuring out finance and like entering in the job market. The other very important aspect of these patients population is their low participation to clinical trials, which is why we are here together today talking about this. And the lack of improvement to survival, as I showed. And there are some biological differences in this cancer compared to younger, older patients with cancer. So all these factors together could lead to suboptimal treatment that may explain at least partially the lack of outcomes improvement that we have seen. So in terms of psychological and physical developmental age, we know that these patients population face a lot of changes in their life in that specific years. They finish college, they start to go to university, they approach the job market. And obviously dealing with the cancer diagnosis in that moment of their life where there are so many changes already, it's not ideal. So these obviously impact on their physical and psychological development. There is a very unique need of imposing autonomy in AYA patients, and the cancer diagnosis obviously threaten that autonomy. And this again leads to a lot of different issues. One of that being not being compliant, or like a lot of these patients are lost to follow up sometimes, and the anxiety that is related can be related to these. Obviously, it's important. Obviously, because they are young, in most cases, we don't have the need to reduce the dose as we do for patients with cancer who are diagnosed in an older age. And there is an alteration of the drug metabolism. Again, all these changes can lead to suboptimal treatment. The location of treatment in patients with AYA does impact the outcomes. We know that hematological malignancies are have better outcomes if they are managed by pediatric oncologists, while patients with solid cancer have better outcomes if they are managed by adult medical oncologists. And the cancer biology is obviously important. We know that AYA patients diagnosed with hematologic malignancy, but also solid malignancy, tend to have very unfavorable genomic characteristics that can affect their response to treatment, therefore outcomes. So this is the case for ALL, but it's also the case for breast cancer. Young patients with breast cancer have often triple negative breast cancer, cannot be treated with hormone therapy, and they have often BRCA mutation, which we know is associated with more aggressive disease. AYA patients are not enrolled as much in clinical trials. If we look at, for example, of patients with hematologic cancer, children with this kind of cancer, with the same kind of cancer, are enrolled in clinical trials in 20 to 40% versus 5% of patients with the same cancer diagnosed just a little bit later. So this is something really that we have to act on. And obviously there are social factors that are associated with poor enrollment in clinical trials. In the United States, one being the fact of not having an insurance, for example, or belonging to some minorities. So there are a lot of barriers and facilitators. This has been presented before me. There are institutional barriers, patients and provider barriers. But the good thing is that we can act on these barriers and try to change the pattern. What about AYA in Latin America population? Most of the data are from Hispanic populations that reside in the United States. And we know that for many solid cancer and hematologic cancer, the outcomes, the survival is lower if we consider Black patients or if we consider Hispanic patients. Even in solid cancer, it can be cured, such as testicular cancer. The survival, just because you are Black, it's 88% versus 96.6%. So I think this is really something that we have to work on. And when we look at more comprehensive kind of social factor, being Black or Hispanic, high poverty, and not being insured is essentially what is affecting mortality. And this is, again, a study that showed that the mortality, despite the incidence of solid cancer being lower than white patients, is higher in Hispanic population. So I would just conclude saying that there are some trials in AYA that have been successful, one being the trial that I lead in testicular cancer. This is a success. We essentially enrolled 716 patients of the 956 during the pandemic. I think if you ask me why this has been a successful story in the AYA, is for a lot of reasons. The main, I think, being the fact that the testis cancer community is very, very unique. We are close to each other. It's a very small group. We haven't had a lot of testis cancer studies in the last few decades. And there is a very high sense of belonging and the acknowledgement that this study is going most likely to change clinical practice if the trial is positive, and the fact that the study is extremely easy on the participating centers and it's been open through the NCORP. So every patient, even in the community setting, can be enrolled in this trial. Those are my conclusions, but I think the take-home message is essentially that we need to work together to change the outcomes of patients with AYA and definitely do a better job to increase the accrual into clinical trials. Thank you.
Thank you so much, Lucia. Clearly a lot of interest. There's no time for questions, but we're hoping that we'll maybe get you in the hallways to really talk more about ways to work together. What we're going to do next is have each one of our landmark insights to give us a quick overview of some of their activities, and we've asked them if possible to comment on the situation in each one of the countries on their young adult population, to try to like put all this together. So this is going to be a quick turnaround. First, we invite Dr. Cuello from Uruguay. Mauricio, thank you.
Thank you very much for have our group here today. Thank you to SWOG Foundation and SWOG. Well, I will try to be quick, despite of the mixture of the large trip and English use, promote this kind of slow motion version of me. But I will try to use the 5 minutes. How much is the time?
4.
4 minutes. Okay.
Yeah.
No? Okay. Well, shortly, our situation, as everybody know, Brazil and Uruguay were the last 2 countries that integrate the initiative. Right now, we have 8 investigators associated to the Uruguay group, 1 CRA that is here, and soon we will recruit another one that we will working exclusively with SWOG trials. Our contracts are in process in an advanced situation. Right now, we are pending to the some number renovation that is a very high process. I recommend avoid the suspension of the number, because it's harder to the first time you try to obtain the number. Our first study that opened is the 2013. We opened in February and have 5 patients right now. And the next study that is in the RE is the 2010, and also the TEMIST in breast cancer, pending SWOG confirmation for our interest also in participating in 3 trials. Okay. Well, we negotiate with the IRB fast track evaluation to SWOG studies. Soon Uruguay will improve the timelines and the Ministry of Health will launch a new regulation process. We have several steps in the hospital and also in the ministry, and they will try to eliminate some of these steps and improve the timelines. After the meeting in November in Montevideo, we select 7 studies, and 2 of them will be presenting later here, one in health literacy and another one in oncofertility. And our next steps have as objective increase our committee participation and also include hematology from Uruguay. We have a very important group there with facilities to perform, perhaps in a couple of months, how is CAR-T therapies. Well, what happened in Uruguay with cancer below 40? To have a numeric idea, Uruguay is 1% of US in incidence and mortality in comparison with US. We have 3.6 million inhabitants, and it's similar the incidence and mortality. Between the age of 14 to 18, they are treated by the same group in one hospital or 2 hospitals. It's the Hospital Pereira Rosell. Most of the patients have the similar pathology with that. Well, the pathology is the high frequency in the age in children. They go to this hospital. In another age, after 18, breast cancer is the more 5.6, ovarian is age. And in the case of cervical cancer, it's 29%. It's a very high number. It's not related with our social indicators and also with the cancer indicators. It's a shame to Uruguay. I can lose the opportunity to say that even if you have a super test to detect HPV or even the vaccination, the problem in our country, if we want to be close to the Nordic numbers, to the Nordic numbers in incidence and mortality, we need to fight against poverty. This is the principal objective, not only super test. In the case of the men's, we have problem with testis cancer. It's very frequent, but the reports in mortality are superior to the reports on the literature. I think that is a problem with the fragmentation of the process of care. Then we have colorectal cancer, and in the both sex, sarcomas, melanoma, lymphomas, and leukemias. We have universal and centralized care by a law that has, I think, the 2 years of time. The access to oncofertility care is free and cover all the population. Our hospital is a reference center in breast cancer, melanoma, lymphoma, leukemia, genitourinary and oncofertility. And all the patients below 40 go to the oncogenetics unit in the country. It has a collaboration program with NCI with a large experience. Well, we are very open to collaborate, and we want to discuss opportunity to work together in this area and this group of patients. Thank you.
Thank you, Mauricio. Our next speaker, it's going to join us remotely. It's Dr. Tane Rebalato from Brazil.
Hello.
Perfect. And I can pass the slides for you.
Please.
Perfect.
Make sure she can speak and we can.
Yeah, why don't we do a trial? Say hello.
Okay. Can you hear me?
Perfect, actually very well. Welcome.
Okay. Thank you. Hello, everyone. I am Tayane Rebelato. I am the medical director of SWOG. It's a pleasure to be here. And SWOG, who are we? We are a non-profit organization founded in 2009 by a group of Latin American oncologists interested in developing clinical research. And we are dedicated to develop and conduct epidemiological and clinical studies in the region. But SWOG also participates in regional and international trials in partnership with international groups. Currently, we are more than 400 members in 16 countries, working in 200 hospitals. Please, can you move to the next? And about SWOG and SWOG, SWOG was accepted as a probationary member of SWOG in October 2021. Dr. Gustavo Berutsky is a member of SWOG Breast Cancer Committee, but unfortunately, we haven't started any studies in partnership with SWOG yet, due to challenge such economic issues, such as funding and operational hurdles, such as regulatory process, but we are working on it to participate in any study. And we are evaluating potential studies case by case to make them feasible in Brazil. We seek to participate in the SLA01 study, which will evaluate gastric cancer in Latin American patients. And please can move to the next. And regarding the cancer in adolescents and young adults, in Brazil, almost 10% of the total cases of cancers occur in this population, which is higher than you present before, than the colleagues present before. Here you can see the 10 most common types of cancer in this group. And it's important to highlight that cervical cancer represents almost 25% of the cases, which is a preventable disease with adequate vaccination and screening programs. Please, can you move to the next? And regarding age group and gender, cervical cancer is the most common type of cancer in women, ages 15 to 34. In over 50% of the Brazilian states, and breast cancer is the most common type of cancer in women, ages 35 to 39. Concerning the male gender, lymphoid leukemia is the most common in the youngest group. Testicle is the most common in men, ages 20 to 29. Tumors from central nervous system are the most common in men, ages 30 to 34. And stomach cancer is the most common tumor in men, ages 35 to 39. As you can observe, cervical cancer, a preventable disease, as I mentioned before, is the leading cause of cancer among adolescents and young adults in Brazil. And I want to share with the colleagues that SWOG conducted studies on cervical cancer, breast cancer, and testicle in Brazil to identify the main barriers on early diagnosis and adequate treatment. And we intend to evaluate the data on young population We also perform a sub-analysis of Amazona, which is a cohort of patients with breast cancer. And from 2,900 patients, 16% were youngest patient. They have more symptomatic, and they were more symptomatic at diagnosis, and they had more aggressive disease at diagnosis. Then we need to focus our attention in this subgroup. And we don't have analysis regarding testicle and cervical cancer yet, but we will conduct it. And it is important to mention that in Brazil, almost 8% of patients rely on public health care system. Then actions regarding studies and other public policies are extremely important to change this scenario. Thank you.
Well, clearly striking numbers to see what's happening in the young population in Brazil associated with cervical cancer, really echoing what Mauricio was saying, and probably just making Dr. Crowley in the back just think about his ideas of really bringing back a GYN committee, or at least a working group, since clearly it's of relevance to the Latin America and of course, the Hispanic population in the United States as well. Next, we're going to invite Dr. Javier Retamales from Chile to talk to us a lot about all the activities happening down there. Javier.
Hi, everyone. I'm Javier from Chile. I have just 3 slides probably. So in GOCHI, we are the Chilean Cooperative Group for Oncologic Research. We are a nonprofit organization as LACO to articulate a number of sites because we are a really long country and we don't have very big sites. We have a just small network of sites. So the idea was activate the network. Unfortunately, it took us a few years, but we could. And now we have 3 sites open. Hospital de Salvador just opened, I think, 2 weeks ago. Having a lot of sites give us the opportunity to open different kind of trials in different kind of sites. For example, in the Instituto Nacional del Cáncer, which is the site 14008, we have radiation, chemotherapy, and surgery, but it's a really small center. So we don't have much patients in that site. But on the other hand, we have the Hospital Sotero del Rio, which is the site 09. It's a huge center that covers 10% of the whole country, but just have surgery, but every kind of surgery, neurosurgery, cardiac surgery, everything, but doesn't have radiation. So it face their own barriers, but with the different trials we are trying to open since long time ago the S1501. The main barrier for the site is that the application to load it's the trial with carvedilol and the cardiac dysfunction. Our main barrier to open that trial is that the application that we use to upload the cardiac imaging is different from Triad. It's a different software, another one. So the new ultrasounds cannot be uploaded in that software. So hopefully something we'll try to figure out how that older version of the software works, but we are in that. The study S1714 was our first SWOG participation. We enrolled 10 patients and then the study closed. So yeah, but it was a fun time for us. We did the training in Chicago for the neuropathy evaluation. I still do it for my patients. It's a good knowledge. And on the other hand, when we are just starting with the site 09, the study closed, so we couldn't enroll patients there, but hopefully something in the future can let us enroll other studies. With the studies involving radiation, there's S1802 and 1827. We haven't been able to open them yet, even if they are already approved by ethics committee, because having the IROC certification to credentialize the radiation therapy technique was not understandable for us at that moment, because even if the study, for example, a barrier of those trials is, even if the study let us do a very easy technique of radiotherapy, for example, true opposed field for brain radiotherapy, we still need to credentialize the most difficult techniques for radiotherapy. For example, for the brain radiotherapy, we still have to commissionate the radiosurgery technique. So for us in Latin America, receiving the phantom, you have different phantoms, thorax, head and neck, and every phantom is a new technique and a lot of time and involve customs. And we need to fight with the customs to not being charged with the cost of the importation, because the phantoms can't be seen as medical devices, but they are not, because we are not using them in patients, or at least that was my justification. And it was so tough that first time, fortunately, some investigator from MD Anderson helped me in the past to get a health phantom, and yeah, in the end it worked out, but it's difficult. But after all the credentialization, we just opened the S1802, but we just submitted the documentation to CTSU. So fortunately, I wanted to open that. It was an open trial, but yeah, we didn't have the certification yet. And the S1902, it's going to be a very difficult trial to open, because we need the National Health institution to get the drug approval, and yeah, more difficulties. The S2010, we are waiting for a Spanish version of the pros. I think they are already up, so we're going to submit it. And the S2013, it's open in the site 9, and we have enrolled 4 patients so far. Yeah, and that's it. Regarding young population, we just have the statistics of the site 08, and there are a few young patients. It's only 2.5% of all patients. So it's not so easy for us to find them in those institutions, because younger patients are treated in the National Cancer Plan for Pediatric Population. So I think that's a barrier for us. Try to get in contact with those patients, even if they are not treated in our institutions. That's all. Thank you.
Thank you, Javi. Well, next we're going to invite Dr. Tatiana Vidaurre from Peru. Well, she comes up here. Some of you may know Tatiana from early times on the SWOG relationship, and we're super happy that she's back to invigorate our relationship with Peru. Tatiana, gracias.
Thank you so much, Dr. Chavez, Darcia, for this opportunity. I will take the presentation. Okay. I think that this is the National Cancer Institute in Peru. It's a main institute. We have around 56,000 patients, a half of the patients coming from the province and the other half from Lima. And this is the numbers of the hospitalary registry in Peru. We have these new cases of cancer in women, looks the trends in breast cancer that is increasing, but maybe can be because in the last years we give access for the treatment of cancer, the coverage, but inclusive in this way is rare, these numbers, because we have a bunch of the oncology service around to Peru too. We imagine that you will decrease the numbers of these cancers. 60% of the cancers is women cancers in Peru. In the other side, we have the cancers in men. Looks like different numbers. Is and in this you can see that 10%, around 20% of our population is young adult, and this population between 15 and 39 years, and women is around 25% in this same range of population. This is the protocols that we trying to open in this new opportunity for the National Cancer Institute from Peru. I think that we can include patients in the protocols that can be observational protocols, and maybe protocols for predictive prognostic factors. And we are analyzing what is the best way, because in the last years, this population inclusive in Peru, the young population is underrepresented in the research or clinical research trial. Maybe the barriers is regulatory and cultural barriers, but we can open some opportunities in this type of settings of protocols. But in the adult population, we can open more protocols. Maybe we intend against to recruit in clinical trials. I think that this all. Thank you again.
Thank you, Tatiana. Now we're going to invite Dr. Nora Sobrevilla from the National Cancer Institute in Mexico. Nora is a GU medical oncologist that it's starting to get more involved with SWOG, so welcome.
Thank you very much, and I hope I can stick to the time. For me, it's challenging. So I'm going to talk to you about Mexico's participation in SWOG, and just to give you a little background, cancer is the third cause of death in Mexico today. And although there are efforts being made specifically by Dr. Mar regarding a register for cancer incidence in Mexico, we do not have still objective data. We do know, though, that around 90,000 deaths are caused by cancer in Mexico. And regarding other numbers, I think it is very important to say that incidence between cancers is different as for many Latin American countries. In men, prostate cancer is still the first cause of death in Mexico, followed by lung, and in women, breast cancer is still the first cause of death in Mexico, followed by cervix uteri, which we know that in many countries it is no longer a threat for women. Specifically for adolescents and young adults, we do not have a lot of data, but we know that around 4,000 deaths are caused by cancer. And here I enlist the main 5 causes of death in this population, led by leukemia, followed by breast cancer, cervix uterine cancer, testicular cancer, and brain cancer. So talking about the National Cancer Institute, we are the second largest medical cancer center in the country in terms of numbers, and we are really organized in multiple services, and that has made it possible to have multidisciplinary committees. We right now have a breast, gastrointestinal, a gynecology, and a genitourinary multidisciplinary committee. And we have a very large medical oncology service. We have 26 staff physicians with 32 fellows and around 50,000 medical consultations per year. Regarding adolescent and young adults, we do not have an adolescent and an IAS committee, but we are working in that terms. Passing to the NCI's collaboration with SWOG, we are part of SWOG since 2010. We already have 5 protocols that are in follow-up. We have right now 2 clinical trials that are ongoing and recruiting. One regarding prostate cancers, we have only 2 patients recruited, and for the lung cancer, small cell lung cancer, 1 patient. And we have 3 clinical trials in process of being approved. Of note, we have the biomarkers in gastric cancer trial, which is an investigator initiative by Dr. Maritere Herrera of the gastrointestinal clinic, and she is a trial PI and champion. Now we are pending approval for SWOG. So staff has been growing through the years in the National Cancer Institute. We are now around 30 investigators involved in SWOG protocols, and we are also involved in SWOG committees. For instance, Dr. Moir at the Prevention and Epidemiology Committee, Dr. Paula Cabrera in the Breast Cancer Committee, and Dr. Oscar Arrieta in the Lung Cancer Committee. What are the future perspective of the NCI-SWOG collaboration? Well, of course, increasing protocols included. We are very open to include, of course, protocols for IAS. We have a very large population of IAS, probably most frequently in the hematology, sarcomas, and GU clinics. So I think we can increase protocols in these terms, also increase awareness of the available potential protocols and other SWOG opportunities, such as investigator initiatives. Of course, increasing participation in SWOG committees, and we are conscient of several barriers that we have. There are no modifiable barriers. I think something we have to mention are access to high-cost drugs, and we have also some problems with approval timing, specifically with some regulatory instances in Mexico, but we also have to accept that we have modifiable barriers to mention one, increasing recruitment. Also, I think we have to identify specifically which factors can be modified in these terms, and also reducing institutional approval times. Thank you very much.
Thank you so much, Nora. We're really looking forward you next joining the GU committee, hopefully. And what we're going to do for the last part of this section, it's to spend a little bit more time learning about our partnership with Peru Colombia. Sorry. For that, we are going to welcome Dr. Eduardo Guerrero. He's also new to our efforts at SWOG. We want to welcome him. He's a radiation oncologist at the National Cancer Institute in Bogota, and we're going to hear a little bit more than 4 minutes to learn more about Colombia. Thank you.
Thank you. Hello, everybody. First of all, thanks to SWOG and the Hope Foundation for giving us this much support. I'm very pleased to be here today alongside Dr. Jesus and Dr. Juliana, who have been longtime collaborators of the initiative. I got a few more minutes than my fellow presenters, but I'm going to try and be fast anyway.
The other hour.
Okay, so a few numbers at a glance. We have an estimated population of 50 million people, 113,000 new cases, and roughly 50% of these patients succumb to the disease. About our institution, it's called Instituto Nacional de Cancerología. It is the largest public cancer institute in the country. We are soon going to be 100 years old. We are now 88 years, have been working for 88 years. And one of our main objectives is to achieve comprehensive cancer control through the care of the patient. We have a very big strength, which is training of human talent. We are the only institution in the country who trains radiation oncologists, and the one that has the most programs in oncology. We try to improve in research, and that's the very reason we are here today with you guys. So, well, how does SWOG contribute to our tasks? We are a high complexity hospital. We give advice to the Ministry of Health. We are a research center, and recently we have been named a university hospital. This is like a title that is going to allow us to improve a lot in our academic responsibilities. But SWOG is crucial in giving us better scientific knowledge, training, and opportunities in research. This is the composition of the organization. I'm not going to stop very long in there. We have nine dependencies in there, but it's not something I want to stop for a long time. I mentioned before the incidence of cancer in the whole country. This is the incidence in our institution. We currently have about 27,000 patients. Of these, 17% were new cases in the year 2022. Most of them are women. 42% of patients are elderly, are over 55 years, and this is something that is particularly important right now, considering the talks we have heard before. Roughly 15% of patients are aged 15 to 44 years, so there is potential for investigation, considering what we heard before. The main sites: skin, breast, prostate, and unfortunately, cervical cancer is still an issue of concern. Regarding childhood cancers, we had 218 cases in the year 2021, with the top 3 being leukemia, lymphoma, brain, and central nervous system. As I mentioned before, we recently got the title of University Hospital. This is going to help us greatly because it allows us to expand our possibilities in academic and oncology training. We have 34 active teaching service agreements, 23 graduates in oncology specialties every year. And as I mentioned before, we are the only program in the country that trains radiation oncologists. These are our lines of research. There are many ones: control risk and early detection, cancer diagnosis and treatment, psychosocial aspects. These are the main projects we work in. And well, how is the research processes doing nowadays? We have 182 protocols active. Most of them, as you can imagine, are purely institutional. Some of them are industry independent, and others are sponsored by the industry, but most are mainly institutional, and we have currently six protocols with the SWOG initiative. These are the steps for approval. I'm not going to stop for a very long time in here, but there are several steps to accomplish before moving forward with the protocols. We also have other institutions collaborating, like the National Cancer Institute, like the International Atomic Energy Agency. We help to fund and coordinate the Red Nacional de Investigación de Cáncer. It is a network. It is kind of young, but it's very promising. 147 members from all over the country. We have our own journal, which is called Revista Colombiana de Cancerología. We have our statistics, and we usually publish practice guidelines, which are a good reference for the other institutions in the country. Currently, we have 6 trials. 3 of them are now in the follow-up stage. 3 of them are pending. We had some problems. I heard our colleague in Chile talking to us about the problems we have in radiation oncology with some certifications, but fortunately we are IROC certified today. We have the capability to perform all sorts of radiotherapy techniques, and we are currently with 3 trials who actively require the participation of the radiation oncologist. So I'm very glad to be able to participate in these protocols. Relevant activities. These are some of the milestones we have had so far. We are celebrating 10 years with the SWOG initiative. I'm going to mention two that I would like to highlight two. The naming of Dr. Acosta as a member of the governing board. And I would like to remind you about the slide which is going to take place this year in Colombia. And these are some of the members. And to conclude, I would like to comment about our strengths. We have unfortunately some pathologies which still have a high incidence, like I mentioned before, cervical cancer. So it is very important to have our own patients and our own evidence in these pathologies. We are a cancer reference center. We have the infrastructure, we have the experience, we have human resources, and most important, we have the will and the drive to go ahead with all these projects. We also face a number of obstacles. There is quite a considerable lack of support in the establishment of agreements with entities. There are administrative difficulties both within our institution and with the government and other entities. We have limited research resources. Unfortunately, one of the main problems we face is that we don't have protected time for clinicians or protected or like an extra remuneration for the efforts in research. It's still mostly something we do in our spare time and with no additional resources. We sometimes face the barrier of language, which is something we all have to work on. And although all these situations can bring about lack of motivation, which is something we must conquer. So basically, it's the same I told you before. We are determined to lead and improve cancer research networks. We want to continue improving training for clinical investigators, something SWOG has been of paramount importance. We want to strengthen clinical research in fellowship programs, and SWOG is going to be crucial for these objectives. This is our SWOG team. Like you guys said, I'm kind of new. I'm feeling very motivated to move forward the great work of some people who preceded me. So thank you so much.
Thank you so much, Eduardo. And that was actually a great way to announce that we are really in the early stages of planning our Latin American Symposium this year in Colombia. So more to follow as we finalize more details, but as you all know, that it's important part of our educational commitment last year. Uruguay, they were just absolutely wonderful hosts, and there was a great conference, and we're really looking forward to Colombia next year. So we may have time for one question or comments, or if anybody has any thoughts about all these potential ways of really synergizing and working on patients that are younger adults with Latin America. I want to make sure that we give time to maybe start our interactive part. Anybody? Okay, we have one time, yeah, over there, Angela, and if you don't mind coming up to the mic so our attendees over Zoom can hear you. Thank you.
Good morning. My name is Angela. I am from Colombia, and I work at DHR Health Institute in Texas. So my comment is about if someone can share some ideas about how we can improve the educational part in research, because I heard some ideas about the educational part, and I learned about that. One of the possibilities why Hispanic population are underrepresented is because the educational part, because they don't know or they cannot understand how important is be part of the studies, and also how important is the prevention. So I would like to hear some ideas about how we can include this topic. Thank you.
Angela, and I think that is like a wonderful topic to discuss and to bring up. I think it's been clearly described that this idea of education and it's a big barrier to participation, the stigma associated with it. I know that Irene has worked on that, Ivan, and we have Dr. Napi wanting to maybe answer to that.
So I think, guys, that one way to, especially for the AYA population, is to have Latin American and SWOG liaisons in our AYA committee. So that would be great to start to collaborate. In terms of education, the AYA committee is working on implementing knowledge about clinical trials opportunities through social media. So everyone in the world has social media access, right? So I think that could be done. Obviously, reaching out to the cancer, AYA cancer patients in the United States, but why not extend it to the Latin America countries, right? So I think having you representatives from the Latin America oncology into the AYA, but also other committees, would be a great way to start these kind of collaborations.
Lucia, we will take you on that
Oh,
and have a liaison on that. We have time for one more question. Barbara, our wonderful powerhouse patient advocate, will say a few words from the patient perspective. That's
exactly.
So
that's the way I'm going. I think that one of the success SWOG has is having patients involved from the concept up to the dissemination. And part of what we know, and is even a lack of advocates, Latina advocates in the United States. I'm kind of the one of the few, right? So part of the thing that we have to do is have more training program to increase the number of Latino advocates. And I have a project with Dr. Amelie Ramirez in San Antonio. We're going to have the Advancing the Science of Cancer in Latinos next February. And I proposed to her to have the first cohort of scholars. We are looking for funding, but to hope to can have 10 advocates. And from there, because usually what they see, they have promotoras and things like that, but we have to empower patients themselves, and especially patients with experience. So we can talk later if you want.
Thank you. Really a topic that we all are very interested in. But we're going to move to the last part of the symposium that it's really going to touch on, one committee specific and the roundtable discussion with Latin American investigators. First, we're going to invite Dr. Lynn Henry to the podium. Dr. Henry is breast medical oncologist. She leads the breast group at Michigan University. She's the co-chair of the Symptom Control and Quality of Life Committee, member of several others, long time, SWOG member with a lot of expertise. She's been a true champion and cheerleader for our, program. She's participated in a number of our educational sessions, and she's the chair of S2010. And this is, we're going to hear from her, this study, it's focused on on patients with with breast cancer that are young. And we do have a lot of interest and plans to open her trial in Mexico, Colombia. We heard Uruguay is ready, Chile. There's been some issues with the translations that seem that they just got up. So we're really excited about being able to participate and help you accrue to your trial. So thank you so much.
Yeah, thank you very much for letting me talk about this trial. It's a perfect segue from the AYA segment that we just had, because this is really focused on young women with breast cancer. And also it's a good segue also to Dr. Fish's next talk, which is talking about symptom management trials, which I think are the ideal type of trial to be open at Latin American sites, because they don't have a lot of the barriers that you find with some of the drug trials. So this is talking about, thank you, ASPEN, which is SWOG 2010. It's a randomized phase 3 trial comparing active symptom monitoring plus patient education, comparing it to patient education alone. And our goal is to try to improve persistence with endocrine therapy in young women who are at high risk of recurrence of stage 1 through 3 breast cancer. So really quickly, so we know that discontinuation of endocrine therapy before the recommended 5 to 10 years because of side effects is incredibly common, and more so in patients with who are young and who are on ovarian suppression as well. Active symptom monitoring is basically frequent assessment of symptoms, usually in between clinic visits. So instead of seeing patients in clinic every 3 months, every 6 months, saying, how are you doing? Really what the goal of this is to reach out on a much more frequent basis, but in an automated way, to get information and improve patient-provider communication. So for this study, we're actually asking 6 very brief questions via either phone or the internet, asking about toxicity, and I'll talk a little bit about what we're doing with that information. And as I mentioned, our goal is to see whether this intervention actually increases persistence, so staying on the medication as directed with endocrine therapy, and also ideally to reduce side effects and improve quality of life. So our primary objective is to investigate the impact over the first 18 months of therapy. Secondarily, we're looking at treatment emergent symptoms such as hot flashes, aches and pains, vaginal dryness. We're also looking at a few measures of adherence, both patient reported as well as checking blood levels. And then we want to really see which patients are most at risk of stopping their endocrine therapy early, and also which patients might benefit the most from this type of intervention. So in terms of the study itself, everybody gets patient education. So we have a handout available in both English and Spanish, and it has links to 3 websites. One is talking about breast cancer, one's talking about side effect management in breast cancer, and one is talking about healthy living. It's actually from that last one is from the American Cardiology Society. And patients who are in the active symptom monitoring arm will get a link to 6 questions, very brief, via email or text or via telephone. And so basically you either would get the email, you would get the text message on your phone, you click on the link, it takes you to a website, and you answer the 6 questions. It's weekly for the first 24 weeks because that's when the patients are at highest risk of developing symptoms, and then it spreads out to every 4 weeks for the next 2 years. Everyone in the other arm of the study just gets the patient education, and you follow up like usual. So this is a schema. You undergo baseline evaluation, which includes some written questionnaires, blood draws, and I'll get to that in a second. Patients are then randomized to either getting the active symptom monitoring intervention or not, and they're started on standard of care anti-hormone therapy. So this is not fancy new drug. This is just whatever the patient and her doctor decides is the best treatment for her. It does have to include ovarian suppression. And then patients are followed up every 3 months, is the way we're currently written. And at that time, they complete some questionnaires, ask about what's going on with symptoms, adherence to medication. At some of those, we have optional blood draws. And then the very last assessment is just by phone saying, are you still taking the medication or not? So stage 1 through 3 hormone receptor positive breast cancer. So patients with DCIS, non-invasive cancer, or patients with metastatic disease are not eligible. Patients do have to be either pre or perimenopausal at the time of breast cancer diagnosis. So that's either self-reported, I'm still having periods within the last 12 months, or you can use lab values, but it's not required. Importantly, and this is a question I've gotten a lot from the US sites that are trying to open this study, is you have to be planning ovarian suppression as part of your treatment. And so this is because we know that these patients are at higher risk for having side effects and stopping treatment early. And ovarian suppression just means you can be giving GnRH agonist therapy every 4 weeks, every 12 weeks. Someone can have her ovaries removed after breast cancer diagnosis, or if someone receives chemotherapy and her ovaries are now suppressed, that counts as ovarian suppression, as long as the intent is that if her ovaries wake up again, to do something about her ovarian function. And then patients will be taking standard endocrine therapy. It can be tamoxifen or an aromatase inhibitor. And we have a little bit of a window. It can go, anywhere from 2 weeks before she's planning to start the medicine until 2 weeks after she's already started it. It's when you can enroll and randomize patients. So we have a little bit of flexibility there. This is really quick. It is unfortunately English or Spanish only. We do not have the capability of having the intervention available in Portuguese. If people had surgery, so everyone had to have had surgery. It has to be at least 14 days before, which isn't an issue. Prior chemotherapy is not required. Patients do have to have access to the internet or to a telephone. And we don't want patients who are planning to become pregnant during the 80 weeks of study participation. As I mentioned, standard of care oral therapy is not provided by the study, the same with ovarian suppression and ablation, which I already talked about. And then I talked about the handouts that people get. There are these standard of care clinic visits. The PRO questionnaires are in English or Spanish on paper at each clinic visit. I know that there are issues with blood draws within the Latin American sites. And so for right now, at least, we've said that it's okay if your site does not have to offer these blood draws to patients. I'm hoping that we're actually able to continue this conversation because there may be studies where we really, really want to be able to get blood draws. And I'd hate for there to sort of be a blanket, no studies that are open in Latin American sites have to ever draw blood on patients because they are important. You know, we're trying to look at why people get side effects. We're trying to look at measures of adherence with blood levels. I know some sites have more issues with genetics and not so much with serum. And so it's okay to, be a little selective in which ones are done. But I hope that this is an ongoing conversation. And then, as I mentioned, there's one additional phone call. So really the intervention is, these are the 6 side effects. The patient gets the link. She answers the questions. If all is well, nobody hears anything. It just keeps going until the next week. But if she is above the threshold on one of these symptoms, which is either a worsening compared to the last time she completed the questionnaire or to the severe or very severe level, then the clinic is notified. And then it's up to the clinic what you want to do with it. The protocol is not mandating that you must do a specific intervention. It's not even mandating that you have to call the patient. But we do have a little form where you say, I called the patient, I got hold of her, or I didn't get hold of her. This is what we recommended, if anything. So it's supposed to be as pragmatic as possible. And then it just repeats again the following week. You will also not be bombarded by patients who are not completing the questionnaires. You do get a couple of reminders that if the patient doesn't complete the questionnaire, to reach out, make sure there's not a technical glitch. But if twice she doesn't complete the questionnaire, you're not going to keep getting bothered after that. Patients will come off study if they don't ever actually start the endocrine therapy, if they become pregnant, or if they have recurrence of their cancer or a new cancer. And obviously it's up to the patient if she wants to withdraw. In order to get started, obviously, once you put it through your local approvals, then there is a training for how to use the ProCore website itself. Once the site is activated, you have to then get access to the ProCore website itself. It is not usually the clinicians who would need to have access. It's more the CRA or the data manager at the site who's going to be getting these direct notifications about the patient alerts in terms of symptoms, but it's up to each individual site how they want to set up their workflow, and I'm happy to help talk through that. We do have the pre-recorded SIV training available on the CTSU site. Unfortunately, it is in English, and there's some frequently asked questions also available in English. So on the CTSU site? On the CTSU website, yeah. And then this is the contact information. I really want to encourage people to participate if you're interested. As I think it was Javi mentioned, we now have the Spanish version of the PROs got approved last week. So we've launched in Spanish in the United States. And hopefully that will allow all of you to move everything forward, because I know that all the different countries have been working on that. And as I said, blood samples are an issue. I hope that is not a barrier to getting your site open, but I hope it can remain in a conversation. So thank you.
Thank you, Lynn. So we're really excited about this, and we really want you to activate and to accrue a lot of patients, as we've discussed. We think that this is one of those great trials for us. Thank you so much, Lynn. And with that, we'll invite Dr. Mike Fish to the podium. Mike, it's actually still, even if though part-time, clinical professor at MD Anderson, and he's the Senior Medical Director of Medical Oncology Programs and Genetics at AIM Health. He is the co-chair of the Symptom Control and Quality of Life Committee, and he's going to talk to us in the next 10 minutes about, what are you all doing and what we think can be a good collaboration for Latin America. So thank you so much, Mike, for being here.
Thank you. Well, I'm going to talk about conceptual models and a little bit of a sort of an overview of how we approach thinking about the committee priorities and goals, and really start with sort of a story about how I got seduced into this realm. I think a lot of people who are interested in symptom control, it all starts with a patient problem that was perplexing to you, and that was true for me. So when I was a fellow in medical oncology, I was at Indiana University in my continuity clinics, and I was seeing a patient with advanced colon cancer who seemed to be depressed. His sister and his wife was convinced he was depressed and thought he should get an antidepressant. And so I said, great, I'll talk to the patient. And I couldn't figure out if the patient was depressed. I asked him if he was depressed in front of his wife and sister, and he said no. And then I staffed the patient with the cancer center director who was in clinic, and he went and talked to the patient, and he couldn't figure out if he's depressed or not. And we called psych, and psych came down for an hour while I saw some other patients. And they said, I don't know if he's depressed, but you could always try an antidepressant. And I thought, there's probably some work to be done on this, and this would be quite an interesting thing. So I got into the area. And I at MD Anderson, I started my career working for Dr. Eduardo Barrera in palliative care, a leader from Argentina and a very inspiring person. And then was also influenced a lot by Dr. Wan Ki Hong, who was the division head at MD Anderson, who said, Mike, your job is very easy, healthy goals and step-by-step processes. And I always think about that, and I've always focused a lot on thinking about the healthy goals, and particularly as it relates to this realm. And really, it's, we learn about just the 6 goals of quality care, from the Institute of Medicine from 20 years ago, right? We've spent a lot of time focusing on effective care, drug development, trying to see what works, things that can be marketed, but what's safe, effective, patient-centered, timely, efficient, and equitable. A lot more interest on that these days in equity as well, but patient-centered, how do we keep the patient in the center? And it seems to me the patient is in the center of our platitudes, but very quickly kind of drifts into the blind spot. And then we have to sort of somehow drag them back to the center. And I wondered about, how do we educate patients about why they should go on clinical trials? Well, how do we get them to understand the trial is for them? The things that we're doing are to help them, because it may seem to them that we're trying to, it's sort of, we talk about bench to bedside and back, but it's sort of like bench to bedside and back starts and ends somewhere other than the patient, right? It would have to be bedside to bench and back if they were to see it as them in the center. But patient-centered, real important part of this. So the Institute of Medicine talked about cancer care being in a crisis, not being patient-centered enough, also being not evidence-based enough and far too expensive. But when I think about, some of the call from that report, it's all about informed, activated patients working with prepared, proactive practice teams, and the successful and well-coordinated system, and leading to good health outcomes. But prepared, proactive practice teams and a informed, activated patient really resonates with me. And then when you look at the other models that came out of that report, the patient is in the middle of it, right? And ultimately, we're measuring outcomes, we're measuring quality things, and we're trying to have a learning healthcare system. So the patient-centeredness models realm. And so then, if we're thinking about the patient in the center, in the end, you have to have kind of a model for the person, right? It's all about the person. And so every person has a perceived future and a secret life, and they do things, they have a body, they have relationships and feelings and all these things. And we learn about a model of suffering. Suffering is, things that threaten the intactness of the person. So healthy goals, conceptual models, and then step-by-step processes. So I think about, when we care for patients over time, from diagnosis to initial treatments and many times line after line of subsequent therapies, we're trying to extend their lives and improve their quality of life. I mean, it's really that. They may not know what, minimal residual disease is about and some other surrogates that we talk about, and biochemical recurrence-free survival and blah, help you live longer and better, right? And I think about, more or less just in my mind, sort of, integrating the area under that curve. That's what we're trying to pull off from the patient's point of view. And you have to understand, what quality of life means to that patient and kind of hitchhike them step by step through it all. And sometimes I think about that not just as a, as a quality of life over time graph, but to bring it into 3 dimensions. I think of it like a tank. I'm from Houston, so we think about tanks of things, tanks of oil, tanks of quality of life. But you think about sort of having a vision for what's the realistic ideal level of fill in this person's quality of life tank for that person. And they may be sort of thinking about or saying things that are more or less in the wishful ideal realm, but we have a vision for them that sometimes, ratchets, we acknowledge the wishful ideal, but we get to the realistic ideal. But then you end up having to figure out where the leaks are coming from. And we may have a name for that leak. It might be aromatase inhibitor induced musculoskeletal symptom, or immunotherapy induced thyroid dysfunction and fatigue. So we're trying to name all these things and characterize them, but to the patient, they're just leaking. They may not have the same words for it. There may be sort of a symptom masquerade, what they call fatigue, you call pain, or what have you. But one way or another, their quality of life is drained down below the realistic ideal, and we got to figure out how to, exactly what we're going to do to patch those leaks and bring them along. And some patients are more affected than others by these leaks because they have sort of a resilience of some kind, some well-being reservoir, whether it's spiritual or coming from whatever, but there's something that kind of fills their tank from the outside, and we figure out what that is and how to connect it to the tank and things like that. So bringing this now to the committee, right? So our committee's vision then is to be the best environment for the development and implementation and conduct of trials, where we're trying to create a new understanding of the mechanisms of symptoms. Think of them as leaks. How do these leaks happen? What's really going on? How do we name them? How do we follow them? Mechanisms of symptoms and new methods to reduce patient suffering. So in the end, it's the patient, it's the person. And in order to do this work, we got to get beyond just the medical oncology clinicians or radiation oncology clinicians. So it's surgeons, nursing, basic science, pharmacists, advocates, biostats. It's like everything else at SWOG, it's a big team effort. We're very interested in early stage investigators, and we worked hard at that. We're trying to, again, keep focused on the patients and really take advantage of our skillful and dedicated NCORE network, including all of you. So we do, we have to prioritize somewhere. We have a bit of a focus. Our clinical focus is on things that like CIPN. I think we saw a lot of interest in S1714 in your places. And it's encouraging to see S2010 having some people opening that up. Immunotherapy toxicity is an interest. We have an open trial S2013. That's an observational study, and some interest in cognitive impairment. And there's always other emerging things, right? A new observation of a new clinical problem that somebody is inspired to try to tackle. And then methodologically, we've had to do some prospective cohort studies, not just because that is entertaining to us, but it's really hard to do an intervention, to figure out how to patch up those leaks. Sometimes you've got to do the painstaking work of really understanding them, and before you can figure out how you're going to patch it up, right? So sometimes we find that we keep trying to propose interventional trials that don't have a solid enough basis to go forward, and then we have to back up and do the cohort studies, get better understanding of it, and then go forward. And there's, as you can see, some other methodologic things that we focus on. But we feel like, there are some sort of research production things that help us measure our success. We come up with ideas, we develop studies, we launch them, we publish them, and but we prioritize things for impact. We're trying to ultimately do things like S2205, this ice compressed study is an example of, we build on this, the observational work that we have where we understand the symptom, and then we're trying to do an interventional trial where ultimately this leads to interventions that make people suffer less. And in this case, it's a novel device intervention with good pilot data. So thank you for your attention.
Mike, always engaging. Thank you so much for sharing your story and also for telling us, about what is happening at the committee and how we, can all think on, approaching symptom control in our patients. And it's clear that's something that we all deal with day to day in clinic. Now, over the last, part of the symposium, what we're going to do is here to brief, and I'll encourage the speakers to keep the brief presentations on some proposals that are coming from Latin America, specifically in Uruguay. So then we can have some time for questions. The first discussant in this, hybrid roundtable, it's actually not here with us today. It's Dr. Dana Kimmelman. She is a gynecologist and an oncofertility specialist at the Hospital de Clínicas in Uruguay. Dana, are you online?
Hi, how are you? Thank you so much.
Perfect. So I'm going to advance slides for you.
Great. Thank you. I'm going to just for a second, I'm going to thank everyone for having me here, and especially John, Lynn, and Dacia for mentoring me on this project. So Mauricio already said that we have a very high incidence of cancer diagnosis in young patients. So in our country, it's around 6%. So we need to take care of their quality of life after treatment. And we know that cancer therapies may impact on their future fertility. And as we know, for these patients, sometimes this possible impact on their future fertility is as stressing as cancer diagnosis itself. So please, can you put the next one? So we all know that oncofertility takes care and considers patients' reproductive health after cancer therapies. And we really believe there is a gap in knowledge on specific oncofertility field. And our hypothesis is that we need to train better our reproductive and endocrinology and infertility specialists to take care of these patients. So please, if you can put the next one. So here in our country, we made a lot of efforts on this. So we started doing like a survey for oncologists and physicians that take care of this population and know where we were to know if patients were being counseled. And we found out that most of the patients were not being counseled by their attending physicians. So this is like the same results we can see in Europe and United States, like around 50%. So we started making a lot of effort to have financial support for oncofertility process here in our country. And we finally have this fertility preservation coverage that's been available for the last year. And we also realized that we needed better education and knowledge for physicians. So we created this oncofertility book, which is the first one in our country. So please go ahead. And we decided to create this project. And what we really want to know is if there is access to formal education for RER physicians in our country and in Latin America. So you can go ahead. So the idea is that we can develop we have lots of guidelines that we follow, but these are international guidelines, usually from United States and Europe. So we really believe that we need our own guidelines from our country and from Latin America. So the idea of this project is to design, to know what is the real situation of oncofertility in Latin America, then analyze this data, realize which is the action that needs to be taken, and then take an action and re-evaluate the situation. You can go ahead. So we want to know what's the situation of REI physicians in Latin America, to know if they know about infertility, how are they learning about this field, and if we can improve this. We also want to know if different countries have resources to build an infertility field in their countries. And the other specific aim is to know how many countries and regions have the necessary infrastructure to develop these programs. Go ahead, please. So what we really need to know, what our general objective is to assess infertility, the REI physicians' knowledge. And then we're going to do a survey that it's going to be asking physicians about their knowledge. How do they get their knowledge? If they assist to conferences, how do they work? We're going to ask some questions about, like, if they know or they don't know the different specific fertility preservation techniques and the safety of those. And we also are going to ask about the infrastructure. This, of course, it's going to be a descriptive analysis, and we are going to try to minimize the bias by trying to have everyone answer this survey. We are going to send the survey to all the reproductive and endocrinology centers in Latin America, which we know there are around 200. Go ahead, please. So what do we expect about this research impact? We are going to make a situation diagnosis about LATAM countries' situation about infertility education. After we know this, we're going to be able to create education tools that we believe they're going to be necessary. We are going to be able to promote infertility courses and textbooks around Latin America, and develop these courses and textbooks and conferences, and try to have access to different countries in the region. Go ahead. So we know infertility has been growing the last years, but we need to continue growing. So once we identify the gap in knowledge, we're going to create these resources. We're going to have our own guidelines adapted to our real situation, and we will have our own education policies. And hopefully what we were able to create in our country is going to be accessible also to other Latin American countries. I think that's it. Thank you so much.
Thank you so much. So we have a few minutes for questions and discussion, and maybe for members of the audience to make suggestions, et cetera, et cetera. So while we wait, I will just want to highlight that this proposal, it's a proposal that was further developed in one of our workshops during the meeting that we had in Uruguay. So just highlighting the importance of, just being all together and hearing from experts. Lynn, John Crowley were great help for the further development of this proposal. And I don't see any hands raised, but maybe something that will be very important for us to think about, Dana, once you launch, this project, since we want to eventually impact the lives of Hispanics everywhere, will be to run a parallel survey on what's happening in certain areas that are known for treating large volumes of Hispanic patients. So we can think, Puerto Rico, the Texas border, et cetera, where the issue of resources and knowledge and time and clinic load could be a challenge for both physicians, and of course a lot of issues for patients. So that will be something maybe very interesting that we'll touch on all the DEI interventions and strategies that Dr. Don Deason is planning on. Any thoughts or comments? Your feedback is always super helpful. But anyway, if you think about anything, we'll just love to hear from that. Sure. What Daisha is whispering behind my ear because she's my best, keeping me on track on everything. Dana, do you have any questions that you may have for somebody here in the audience, or maybe just a poll or feedback from Latin America?
No, I mean, we are planning to start with this project as soon as possible. Because the survey is already designed. I have received a lot of help from Lynn, that she made a suggestion that it's pretty similar as what you said recently. So I know I have the support from all of you. So probably I will contact you with some questions in order to improve this, and we hope it's going to be good.
Wonderful. Well, if there are no more questions, then we'll invite Dr. Ivan Lira to the podium. He's also from Uruguay, even though like he's from Mexico. And he's gonna talk to us about a project on health literacy in Latin America. It's a sub-study of his 2013.
It's separate.
Oh, no, he is a PI of or is developing a sub-study as part of S 2013, but he's going to talk about a different project right now.
That's right. Okay. So thank you very much, everyone, for being here. I really appreciate the support provided by Hope Foundation. So, all right, let's start. At this time, I would like to, thank you. I would like to present this study proposal, which I think is going to be important and could be related to what Angela Varela just mentioned and asked to all of us. Dr. Finch could be also interested in this kind of information because it's related. We're not just like, this is beyond just prescription of anti-cancer therapy. This is more patient focused, and I'm pretty sure Dr. Napi could be interested as well. So as a background, we have to remind that in Latin America and the Caribbean, some projections estimate that 1.5 million of new cases of cancer and 700,000 deaths could be related to cancer annually. And this is quite new information, and the trend is not going to be going down. This is going to going up, and unfortunately, this is going to be a more significant issue for governments and healthcare systems. As we can see, according with the World Health Organization, healthcare is defined as a cognitive and social skills that determine the motivation and ability of individuals to access, understand, and use information to promote and maintain good health. So this is quite important because most of the times we believe that we are clear enough about our prescriptions, and we clear our mind and said, well, you know what, this is the information that you have to analyze, and this is the kind of prescription that we have to follow. But the truth is, most of the times patients are not able to understand what we are saying, and sometimes this is related to low or increased toxicity rates and other significant issues that at the end of the story will impact on overall survival and other like IDFS. So now, low health literacy is associated with poor health incomes and poorer use of healthcare services, because even when we prescribe ondansetron or other kind of or symptom-related medications, if we are not clear enough or the patient is not good enough to understand what is the way that they have to use the medication, they're not going to take it in the right way, and most of the times they will deal with toxicities that at the end of the story will make that the patient will decline to continue with the treatment. So that's why we believe that the rationale of this for starting health literacy in patients from Latin America is crucial for improving cancer outcomes in this population in order to identify the gaps in knowledge, attitudes, and behaviors that affect cancer outcomes in this population. We do know that this kind of information could be already discussed in some parts of the US, but as Dr. Napi mentioned, most of the times the information comes from small studies for Latin American population based on North America, and it's not in where all the main information from the Latin American population is available, which is Latin American countries. So now this research can inform the development of culturally and linguistically appropriate interventions to improve cancer-related outcomes, such as increasing cancer screening rates, promoting early intervention and detection programs, and improving adherence to treatment. What do we know right now on the field? Well, in Uruguay, we're working with some doctors in Louisiana, because obviously we have to look for the best survey, well designed and approved for this population. It's not just grab some surveys and said, well, I'm going to take these 3 questions and let's see how it goes. No, we have to validate the instrument. And this team has a validated one that we are using right now in Uruguay. And we can see that 92% of the patients have some kind of issue understanding the information that we are providing. And only 18% has minor issues, but 74% has major issues to understand the situation about how they have to take the medication and to understand what the physician, and in this case, the medical oncologist, is trying to explain the treatment and the way that they have to deal with their new disease. Therefore, in this study, the main objective is to describe the healthy literacy levels in cancer patients in Latin American countries. Specific objectives, well, is going to be identify whether there are an association between time to start diagnosis and health literacy levels in cancer patients in Latin America. For us in Latin American countries, because I'm from Uruguay, then from Mexico, then I had a time in Canada, and then in Uruguay, I have the chance to understand that there are like different kind of situations that are affecting the way that the patient deal with the disease before the diagnosis. Sometimes in Latin American countries, we try to be very reluctant to visit the physician until we have like severe symptoms, and until we have the bowel obstruction, instead of visiting the doctor when we have like the bleeding, isn't it? So this situation is important, that we have to try to find a way to measure in the best possible way how much time, if there's any, the patient is waiting from the first symptom to visit the physician and then to have the diagnosis. And we would like to correlate this information with the health literacy level, because we think that this information could be important for us to develop further analysis and further actions. The design, well, is going to be a cross-sectional study. The inclusion criteria I would like to show this information, but I'm happy to have Dr. John Crowley's feedback in this situation. Sorry, Dr. Crowley, but let's try to think in this. During the Uruguayan meeting, we thought in something, but now we are thinking about including newly diagnosed patients with cancer within the SWOG slide members. Obviously, in this case, because of the instrument and validation of the instrument, we are looking for Spanish-speaking patients, not the Portuguese ones. So this is going to be important to mention. Patients over 18 years old and solid tumors at the clinical stage 1 to 4 with with the PAD report confirmation. Exclusion criteria, well, patients that are unable to respond or to answer the questionnaire, and patients who did not provide the informed consent will be excluded. Obviously, patients that are already in the ICU unit or something that were operated, that had a surgical resection or something, that are unable to provide a good response, are not going to be analyzed. Methods at this time, we are looking for 100 patients. Cancer patients will be recruited from for every single cancer center in each country that could be interested in joining us. The health literacy assessment will be the one that it's already validated. I can show and have more discussions about this instrument. Cancer outcomes will be measured using patient medical records and also self-reported data. And well, the descriptive statistics will be used to characterize the health literacy levels in the study population. Logistic regression and analysis will be used to investigate the relationship between health literacy and cancer outcomes, adjusting the 4 potential confounders such as age, gender, education, socioeconomic status, and well, other statistical tests that we can use. We can just leave it there. but I'm happy to have some kind of feedback from you, because I think that this kind of study could be important for us as a region, and also could be more important to develop other strategies for the rest of the oncological community. Thank you.
Thank you. Thank you so much, Ivan. And we do have short time for questions, but we really want to get feedback. So I see Dr. Henry in the back. She raised her hand while she runs to the mic. I think it's really something that what we learn can really help us, accrue more patients. Lynn?
Yeah, so I think this is great. I think there may be a bit of a challenge to try to look at health outcomes in this population, but I think that thinking about the endpoint is great. My one comment, and health literacy is not something I know a lot about. There must be a way to assess health literacy in people who can't read, because I think you'll be biasing your sample a lot. And so I think investigating how people have done that in lots of populations, including those who aren't able to read it for themselves, I think would be incredibly important.
That's right. Unfortunately, Dr. Lin, we have this kind of a question before in the back of our heads, because at the end of the story, most of the times, those kind of patients that are unable to read, they have to, most of the times they use some kind of familiar support, but sometimes they use other persons that are like aware of the patient. So it's kind of difficult, and I'm not quite sure how to solve this situation, because it's an important bias, but there are like different people like involved in this, and it's difficult to sort this out. So thank you for the comment, and I'm pretty sure that we will take an eye on it.
Hi, my name's Joanna. I'm a health services researcher and GI oncologist at Columbia. And a lot of my work actually has been in sub-Saharan Africa, and more recently collaborating with cancer centers in the Dominican Republic. And I mean, this is a super important study, and a type of study that has been done by our group in South Africa with breast cancer patients. So what we found is breast cancer knowledge using a survey or tool that we validated in the South African population was really correlated with stage of diagnosis and also prognosis. And something to think about if you can or have the capacity to add to your study is we've found very strong correlations with distance from the cancer center. So how far away patients live is very correlated again with stage of diagnosis, not so much I think with outcomes. And then in terms of health literacy and ability to read, we come across this a lot in our South African population, and usually requires patients can't answer the questions on their own, like using an iPad or a telephone. So it's usually we have to have a research assistant or nurse read those questions to them, and we can get around the inability to read if that's a barrier. But yeah, I think this is a super important study. Then you're going to learn a lot about barriers to care and also trial enrollment.
I appreciate your point of view, and I would like to have your email because sharing this information could be important for me. Thank you.
And then we'll have Mike, and then Nora.
I think this topic is very important, but I kind of wonder what the perspective of the patients may be. Sometimes when you're trying to study a vulnerable population and do descriptive research about their vulnerability, they're very protective about that, right? So it's sometimes, sometimes hard to get people enthusiastic about having their vulnerability just described, and they're thinking, what is this for? How is this good for me? It's hard on my dignity that you're just going to describe how poorly I can understand health issues. So sometimes I wonder if you could somehow package some interventional component, that there's some spirit of doing something about it while you're also describing it. So the descriptive data is part of a bigger picture, but it's not just descriptive.
Thank you. What we are trying to do is to link this study with other kind of situations and analysis that we are trying to do, because if we go straight forward to this questionnaire, sometimes it's like a little bit like aggressive for the patient, because we are asking about income and other situations. So we have to be very careful and try to say that unfortunately, I have to say that most of the times patient has some kind of like bad feeling about how they had the attention and how much the patient delayed to get the diagnosis. So most of the times the way that we try to approach the patient is saying, well, you know what, we're trying to understand how can we improve, because this is we understand that you had a good experience, probably a bad experience, but if we want to improve this situation, we would like to know what's the patient's perspective, what's the patient reality, and then to get this information will improve this journey. So that's why.
I think you're right, emphasizing why we're doing it, and that it's meant to improve on access will probably help with that. I think we only have time for one more comment, and though that Mauricio, it's like looking at me from there, but Nora, you are going to have the last comment before we close.
Okay, perfect. So very interesting project. I think in Mexico we will be very interested in participating. Just two things. One is that in many countries there are people who don't speak Spanish, so you have to deal with what are you going to do with these patients, if you're going to exclude them, or maybe like make the contact with the family that does speak Spanish, because I do have patients that doesn't, or they speak very little Spanish. And the other thing is we did a study at the National Cancer Institute for several tumors about time intervals for diagnosis. And we have a very large time interval for the patients to being diagnosed and get to the medical center. So you will have a lot of memory bias there. So I think you should just be conscious that many patients they are diagnosed maybe 4 or 6 months before they get to the cancer center. So just for you to know that maybe the symptoms thing will be like kind of cloudy for them when they are when they are interviewed. So
thank you. Yeah.
It's about the comment of Lynn, and also we'll try to explain in English. If a people can read, or if a people can speak Spanish, please, it's not ethic to study health literacy. Help these people with all of these tools, but have a very important limitation. It's not important to know the level of health literacy. Probably it's quite sure that they have the minimal tools to manage in the health system. This is people that can read in the 2023. It's a big problem. It's not a problem of health literacy.
Well, I think we will for sure continue these conversations and get in contact with more members of the audience that can really help. So with this, we're already 6 minutes late, so I fail as a chair at the symposium. But I want to start by thanking our presenters. I continue to learn every time I'm here from all of you. Continue to encourage you to stay active, and of course thank the Hope Foundation, Ops, leadership, and the SLAY core team for me. In the back is John Crowley, but he's always in the front for us. So thank you for all your leadership, and Rachel, Kurt, Daisha, like you guys are amazing. It's my privilege to work with you all. So thank you so much. Don't forget the plenary tomorrow. We're going to be talking about SLAY, and we'll see you around. Thank you so much. Oh, and thank you to everybody virtual. Thank you.